Thanks very much. That's great. So whilst the speakers are talking, if everyone could just keep their speakers on mute just to limit any background noise, that would be fantastic. I'm really delighted for the first kicking off this session, we've got our national and international expert, Professor Sally Singh, who is a cardiac and pulmonary and cardiac rehabilitation lead at Leicester, but also leads us nationally in terms of NACAP and the accreditation, PI accreditation scheme. So we asked Sally to come along today and talk to us about why is it important that we get back to face-to-face pulmonary rehab, and we asked her to give a national lead perspective on the importance of this return to face-to-face. So if I could hand over to you, Sally, that's great. Thank you.
Well, thank you, Teresa, and a pleasure to be here and have the opportunity to discuss this, because clearly it's a really important and challenging. I think we all understand that the impact of COVID has been immense, in that largely access to rehab fell off the edge of the cliff. And I think that, you know, many services did an amazing job to support people through this pandemic. But of course, we know that people sitting at home, probably like a number of us, you know, slowly deconditioned during the pandemic and needed to start doing exercise. So I think there's lots of reasons why we need to start doing face-to-face rehabilitation again, not least because we, you know, should all want to deliver a high quality service for patients with COPD. And what we were delivering during the pandemic, it's difficult to, you know, whilst we were all supporting patients, and our centre did probably the same as many of you, you know, we had different menus of choice for patients, but we weren't allowed to assess people fully. You know, we could do some of it over the phone, but clearly doing an exercise test was immensely challenging for this during this time. So I think opening up rehabilitation services to do face-to-face assessments is absolutely crucial, and I think the most crucial component of that is actually conducting the exercise test, and of course that would be the 6-minute walking test or the incremental shuttle test, so that we can accurately prescribe exercise and monitor desaturation as well. There have been a couple of systematic reviews during the pandemic, excuse me, that have looked at exactly these challenges and concluded that it's very difficult and imprecise to prescribe exercise from anything other than a shuttle or a 6-minute walking test. Step tests are quite difficult. I've actually got quite a lot of feedback on mine. Is everybody muted? I think I can hear somebody's television in the background.
I think they've just muted themselves now, Sally, I think.
Slightly distracting. So I think that, you know, offering face-to-face rehabilitation is important. That's what the quality standards in the British Thoracic Society say. That's what the accreditation process anticipates, and that's what's reflected in the national audit. And the audit was actually slightly ahead of the game in terms of being pandemic proof to a certain extent, in that it allowed us to monitor what type of programs were being offered to patients. So pre-pandemic, those of us that were offering different types of rehabilitation actually could record that in the audit, but hopefully you've all looked at the national audit report, and 98% of the 12,000 plus patients that were entered onto that data set did centre-based rehabilitation. You know, so not even 2% of the population offered home-based rehabilitation after that initial assessment. So I think there's a lot of scope to explore how we might offer rehabilitation in a different way. But it does have to be evidence-based. You will have read the systematic review in Thorax this month or last month that looked at unsupervised exercise for patients with COPD and found that it wasn't effective in terms of improving people's exercise capacity. So I think that if we continue to offer unsupervised exercise to all patients with COPD, we're actually doing them a disservice. I think we need to be more sophisticated how we offer care and look at what type of rehabilitation may suit certain types of people. And I think the advantage of the pandemic is that people have experimented with different ways of delivering and are perhaps a little bit more open to doing it differently than they clearly were pre-pandemic, has, you know, where we saw virtually 100% of people did centre-based rehab, which of course excludes a huge number of people that don't want to travel to the hospital, don't like groups, you know, the times are wrong, etc., etc. So I think there are real opportunities to increase the scope of rehabilitation, but we can't compromise on the quality. And I think that's the really important thing going forwards, that we need to do a comprehensive assessment pre and post and evaluate these new models of care so that they do become, you know, high quality and evolve. And clearly all of us sort of rushed at doing something different, which was absolutely the right thing to do. But we now have a responsibility to revert back to broadly what we know works and adapt it in terms of the learning that we've secured as part of the pandemic. So I hope that summarises the position. And I did a talk yesterday for the respiratory networks, or the national leads for the respiratory networks. And that's very much the emphasis now in terms of reopening services to the point where we're not quite sure in June if we're even going to be obliged to observe social distancing in a rehabilitation programme. So there's clearly lots of concerns around capacity for group-based rehabilitation, but there were hints yesterday in this national meeting that that might not be a consideration going forwards, which will be interesting. So we hope that those people that aren't motivated to follow a home-based programme, albeit with support from rehabilitation teams, will be allowed, you know, the high quality care that you all offered and we all offered prior to the pandemic.
That's great. Thanks ever so much for that really comprehensive overview, Sally, of where we're at and what we really need to be thinking about to get back to those quality standards that we know we need to be working towards. It's one of the few evidence-based interventions, you know, that we have for these patients. So we really need to be doing that and doing it to a high standard. So whilst, please everybody, if you have a question, please pop it in the chat bar. I'm not sure if you'll have a function for putting your hand up, so please just write something in the chat and we can read that out for you. While people are having a think about that, Sally, what are your thoughts about, you mentioned exercise prescription, and we know that's so important to do a good quality exercise test to get prescription right. What are your thoughts about some of the alternative exercise tests that people have proposed?
Well, I think that, I'll say a couple of things about that, in that one of the quality improvement markers in the national audit is around conducting an exercise test to the technical standards that were written in an ERS document that has been adopted internationally. So that talks about doing a practice walk, and we know that, you know, only about half the patients actually do a practice walk. So I think for us returning, there is a real quality agenda there that we should all be aspiring to meet, that we do the practice walk. Interestingly, the number of centres, or the proportion of patients that did a practice walk, were higher in centres that had used the incremental shuttle. So that's really interesting, and I don't really know why that happens. Secondly, those centres that use the 6-minute walk, 13% of centres use the correct course. So just to flag that up in terms of quality improvement targets and how to conduct a good assessment, I think that there's room for improvement. You know, some people are doing great jobs. In terms of alternatives, people have commonly talked about the 1-minute sit to stand, and that's really been the focus of 2 reviews, one by Anne Holland and the second one by Lindsay Houchen. And they both broadly came to the same conclusion, in that there's not a lot of evidence for conducting a sit to stand remotely. Secondly, we know that it doesn't relate particularly well to peak oxygen consumption, so really challenging to prescribe an exercise program from. And finally, we know that people don't desaturate as much on a sit to stand as they may on a walking test. So in terms of looking at oxygen prescription, then there are challenges around that as well. So for those of you that are interested, I would direct you towards the review by Anne Holland that was published in the CRD, and Lindsay Houchen's was published in ERJ Open.
That's great. Thanks ever so much, Sally. We have got a question that's come in actually, which goes back to some of what you said about the roadmap. From Liz Hill, has asked, what is everyone's understanding from the national roadmap as to when we can start face-to-face groups indoors? Goes back to what you said earlier, I think.
Yeah, I think we're looking to start now. We're now negotiating gym time because the MSK physios seem to have made a land grab for the gym. So we're now negotiating because, of course, they've got enormous backlogs. We've got enormous backlogs. So there is a bit of a battle going on, and I'm sure you're all facing similar challenges. But there's no reason, our trust in principle are very happy for us to continue or restart seeing patients face to face. We've been running COVID rehab classes all through the pandemic, but not for COPD. But they're now happy for us to start seeing and assessing people. We're now just negotiating space to run our face-to-face programs in the hospital environment, and the gyms, our leisure centres haven't opened up to us yet.
I wonder what's going out for everyone in the community or out in the audience here. Has anybody got anything they'd like to share? Please feel free to unmute or put something in the chat bar.
Hi Sally, it's Liz Hill here.
Hi Liz.
Hiya, I'm not coming off video because I'm in my dressing gown, love, so I'm not coming onto video, but I'm more than happy to speak. Thanks for answering that actually. It's tricky, isn't it? Because obviously I can see your perspective being hospital based, but many of us, like has just been mentioned, many of us are community based. And I think the issue I've got is that we're dealing with national agreement as to when community centres, village halls, etc. can open up to let us use them. So I was just wondering what anybody else out there is kind of planning really. I think from my perspective, I'm looking at obviously not before May 17th, because obviously we know adult exercise groups in theory can meet up indoors after that point. I just wondered what everyone's thoughts were really. Oh, there's a few comments coming in.
Hello?
Hello, Beverly.
Hi. Sorry, it's a bit background noise. I'm just driving.
We can't hear you very well, Beverly.
But, I'm listening on. I'm actually going back to community-based rehab in June, so doing them from venues in our trust.
I'm sorry, I think we're losing you, Beverly. I'm sorry, Beverly, we can't hear you. No. I wonder if we could come back maybe to you, Beverly, in a little while. If you could try again, that would be great. I don't know what you think, Lucy, if that's really, we're starting to get into some of the practical sides of things. So whether it's a good time now to listen to some of the clinicians that we have with us today to talk about some of their practical experiences.
Yeah, absolutely. We've got quite a number of comments coming in about some of the experiences of our clinicians. So it'd be good to get our speakers, and then we can have a bit more of a discussion as a group, perhaps. So I'd like to invite, and delighted to invite, Karen Ingram to speak to us. So she's a highly specialist respiratory physio leading the Harefield Pulmonary Rehab team, and going to just share with us a bit of experience of delivering face-to-face pulmonary rehab when it's been possible over the last kind of 12 months, thinking about the challenges and the adaptations and plans moving forward. So I'll hand over to you, Karen.
Thanks, Lucy. Hi, everybody. Yeah, we've been quite fortunate in that after the first lockdown, when things opened up, we've been managing to keep some face-to-face activity in one way or another throughout. And yes, there have been loads of challenges. And some of these will be common to everybody with all the infection control and the rules and regulations and things. So I wasn't going to dwell loads on the challenges, because I think people are quite aware of those. But I don't know, I thought it might be helpful for us to share some of the adaptations that we've made to kind of get things back up and running. So from an assessment point of view, we had to move off site, free up space, and to reduce footfall in the hospital. So we were able to find some just some church halls or community.
Talking about restarting, we've already restarted.
Can we all just mute? I think we're muted.
Okay. Yeah, so we were able to start doing assessments in these venues as long as we made them COVID secure. So it was very much about getting the risk assessments in place, staggering appointments, one-way systems, PPE, face masks, the works really, so that we could have patients in a large, well-ventilated hall by themselves or with only one other patient on the other side of the hall in order to start our assessments again. And then we sort of had a similar approach with the classes as well. And there's only been a few venues that have been big enough for us to make it worthwhile, because by the time you've socially distanced everyone out to actually fit 6 to 8 patients in to make it worthwhile, there's a limitation on the halls that you can use. But we've kind of managed to get certain procedures in place. So things that people probably will be very familiar with about doing the pre-COVID screening with patients. So for assessments, we're ringing them the day before. For our classes, it's quite unworkable. So we've been getting patients to fill out their COVID screening and turn up with them, and doing the temperature checks, the one-way systems. Our trust has insisted that all patients have to wear a face mask, which I think is probably going to be a bit of a controversial, but because of the risk to other patients in the room. And they're well aware that people might have medical exemptions, but their rule was, in order for group exercise to happen and be safe for everybody, surgical face masks needed to be worn. And if people couldn't tolerate that, then we would try the remote options. But on the whole, people have actually managed really well. And, if they've done their walk test and they needed a breather, they can go outside and remove the mask and have their breather. And so again, we've been able to work within the restraints, really. And staff themselves have been in full PPE, face masks, visors, gowns and gloves and things. And then again, the actual sort of structure of classes is probably the thing that's changed the most, with everybody in their areas. So having their own sets of weights and pulse oximeters and stopwatches and bits, so that they're not sharing or kind of cross-contamination. And again, just all the cleaning and kind of setup and the ventilation. So a lot of things that I'm sure most people are already kind of putting into their risk assessments. But it's just to encourage everyone actually that it does work. And we've had patients really enjoy coming to their face-to-face classes, and they've, even patients that have been to rehab in the past have gotten used to the new way of attending. And so, yeah, it has worked, just to encourage everyone who's hopefully heading down that route. So they were sort of my initial thoughts. I'm very open to questions or to kind of chat through any more specifics, but I thought I'd just start with that, really.
That's fantastic. Thank you very much, Karen. It's really helpful to hear, as you say, how you've adapted in your experiences to share as a group. We've got loads of different comments coming in. So if it's okay with the group, I'll perhaps use these just to guide our discussion a little bit. There's been talks about people using different spaces and hoping to get back to using different spaces. And as you alluded to, it's essential that we think carefully about risk assessment. So there's comments around using community buildings. So a question for the group really: has anyone had any experience so far in going back to using community buildings and your risk assessment around that? Is anyone in the group? I'll just scroll through the chat and see if anyone has. I know we've got an example of a county showground cattle shed, which sounds great. I'd love to hear more about that if you'd be willing to speak to us, Rachel.
Hi, yeah, sorry, my name's Rachel. I'm from Cornwall, so we've had to use our agricultural background really. So when the pandemic first hit, we did a review of our patients, and we realised that actually in Cornwall, with our high retirement age, that being able to engage with anything digitally was going to be really, really challenging. And when we did a review of our patients, 85% said that they couldn't or would not engage with anything digitally or virtually. So we had to think outside the box. My dad's a farmer, so I contacted the county showground, which they have cattle sheds, which are like aircraft hangars, and we have 2 aircraft hangars, and negotiated £15 an hour for the whole of the county showground. So we've got a bit of real life really as well, so we can challenge there with different surfaces. We've got slopes, we've got some hills. When it's inclement weather, we can go inside the hangars, but with the big doors open, there was issues with noise, and wind and rain on a galvanized roof doesn't work very well for your voice, and actually having to get everybody to hear you. But we've had amazing results, and we've had 1 person drop out so far, and we've been running them since July last year, all the way through. Again, risk assessed within an inch of its life. Got legal sign off from the trust as well, and infection control came down, but also I think the patients really enjoyed it. I mean, we had Kelly's ice cream that came along as well, so I think through the pandemic we also got them to have an ice cream at the end and their final assessment. But it meant that we could do their initial assessment and their final assessment, and actually still got that that camaraderie that you often get with pulmonary rehab. The other thing that we did, Karen, is we, because we had such a vast space, we risk assessed them into 6 patient bubbles as well. So again, we were managing to meet the government criteria, so we could bubble them into their exercise components, and we changed how we ran pulmonary rehab as well. So we ended up doing 20 to 30 minutes of cardiovascular exercise, and then did sets and reps in their bubbles, and it's worked really well.
That's fascinating. It's great to hear the kind of lateral thinking outside of the box in terms of space use during the pandemic, and I think that's one of the best examples I've heard. I love it. That's brilliant. Just on the note of thinking about the numbers in the group, someone did actually ask the question, Karen, about is your face-to-face one-on-one or group-based? I believe you've been doing groups, haven't you?
Yeah, we've been doing groups. So with all the social distancing, it's been about groups of 8. And I know someone else asked about whether we've stuck with cohorts or not. And we haven't, partly because if you've only got 8 to start with, and you have either people who can't attend or drop out, the class size then shrinks, and sort of, again, the ratio of staff to patients doesn't really make it viable. And we felt that with all the social distancing and PPE, that actually it didn't need to stick rigidly to a cohort, and having 1 or 2 people, you know, joining in, or it didn't kind of cause any massively increased risk. So yeah, just to answer that one as well.
Lovely, thanks so much, Karen. I'm wondering if we perhaps move on to our next speaker, Ellen, and then again we can come back to the chat and continue with our discussion perhaps for the remainder of the time. So again, just delighted to invite Ellen Galley, and I believe we're joined by your colleague Helen Turner as well, if I'm correct, Ellen, from the Impact Plus team, which I believe is improving adult respiratory care together. So pulmonary rehab, and I believe you're from the Derby team. So it would be fantastic to hear your experiences as well, any challenges, adaptations, and just thoughts for the future. We'd be most grateful to hear from you.
Hi everyone, so my name's Ellen.
and I'm the lead for the Impact Plus team at Derby. We have done a presentation just because there's two of us, just to keep us on track. So bear with me a second. Let me go to slideshow. Can everybody see that? Yeah, you're happy if I just go through sort of slide by slide? So there's myself and my colleague Helen Turner here from the Impact Plus Derby team. So I've just gone through to start with a bit of background to our service. So we're not just pulmonary rehab, so we are an integrated community respiratory team. We're a very large team, there's about 32 of us all together, a mix of 3 consultants, nurses, occupational therapists, physios, respiratory assistants and fitness instructors. So we're quite a large team covering the whole of South Derbyshire and Erewash. The physios themselves are a team of 5 physios and 3 fitness instructors. We have one central pulmonary rehab location, which is a hospital-based location at London Road Hospital, which is the community hospital for Derby. And then we've had 4 satellite sites based in community gyms throughout sort of South Derbyshire and Erewash. And throughout the last couple of years, we've also done some pop-up pulmonary rehab courses in the more sort of possibly more remote areas to try and get better engagement from those patients. And before COVID, we had no virtual option available to any of the patients. So processes before the London Road, the patients would have like a 15-minute triage, about 4 weeks in from their referral, and that was face-to-face. They'd then get assessed 2 weeks prior to starting the course, which would be the incremental shuttle walk test and the 1 rep maxes for the exercise prescription. And it was a 6-week programme, discharged within 2 weeks of completing. At the satellite sites, the only real difference was the triage that was done by telephone, just because of sort of the complexities around getting space for doing the triage at those locations. And we found that people don't really like to travel. So we tended to just do that bit over the telephone. So pre-COVID, we had a bit of experience of doing some of the assessments over the phone, but still majority of it was done face-to-face. Then obviously COVID strikes. So all, like with everywhere else, all current programs stopped, whether that was midway or some patients that have been assessed ready to start the very next day or the next week. All of it got cancelled by telephone, and advice was given to those patients that we'd already assessed in terms of them continuing with a home exercise program. So they weren't kind of just left with nothing. We felt very conscious that we wanted them to try and continue on their journey as best we were able to at that time. Helen, I'm so sorry to interrupt, but some people are having a bit of difficulty with the sound, with hearing you. I'm not sure if there is anything you can do to, if you've got any headphones or anything, just to try. Yeah. Sorry. Bear with me a second. Yeah, of course. Sorry about that. Can anyone hear me? I can hear you. I think there's just a bit of a muffly sound as well.
Is that better? Can people hear me now?
Yeah, that's better. That's great.
Thank
you so much. Sorry for
no worries. No, that's fine. So then we sort of like with everyone else, we looked at the virtual options that were already available, because we wanted to try and see if we could use something that was existing. So we looked at all the existing programs for virtual that are already available, because our service doesn't only see COPD. We have a very large proportion of our patients that are ILD, bronchiectasis and asthma. We felt that not one program sort of covered all of our cohort of patients. So we went along the road of trying to adapt and create our own virtual program. So we're fortunate enough to have some fabulous fitness instructors, and they worked on adapting our current program structure into a virtual version. And we developed both a handbook version and an online series. Because I think, as Rachel said from Cornwall, we very quickly became aware that not everybody had online access, or if they had online access, they didn't have the competency and be able to use it effectively for the needs of the programme. From the physiotherapist perspective, we worked on sort of bringing the education together, developed the handbook version of the education, and also recorded all of our pulmonary rehab talks online, so that we had that online availability for that. And we did some focus groups with our maintenance patients. So we've always had sort of phase 4 patients, and we invited them, once we developed both aspects of the handbook and the online, for them to view it first and to give us that patient perspective on what we developed. And that was really, really useful. So our handbook was launched in July 2020 for when we were able to sort of safely get back to doing that. And initially we started the patients that had been stopped midway through their program, or they'd been assessed and not started. And those assessments were done over the phone at that time, because we weren't able to see them face to face, but we were conscious that we wanted to get them started. So we did do some virtual assessments over the phone, and only really because we sort of clocked eyes on them and we knew what their physical ability was, that we felt that we were able to do that at that time. But when it came to looking at new patients and getting new patients booked onto the virtual program, we felt that we needed to wait until we were available to do the assessment face-to-face, which I believe was around July time. And then we launched our online program in September 2020. So that just took us a little bit longer to develop with the audiovisual team and sort of the logistics around that. So I'm just going to hand over now to Helen, and she's going to talk through sort of how our virtual program has sort of compared to face-to-face, and where we are now with our face-to-face restoration.
Thanks, Ellen. Are you happy to click through the slides still for me? Thanks. So once we started taking patients through the handbook and online programs, we sort of developed a bit of a gut feeling amongst the team that the patients who were on the virtual online program seemed to sort of do better than the handbook program. So we tried to do a little bit of a comparison of the results, really. I'm certainly no statistician, so this we kind of have to interpret the results with a little bit of caution, but we kind of looked at the percentage of patients that met the MCID for each outcome measure that we use, or some of the outcome measures, and we kind of saw a little bit what our gut feeling was. So with the 1 minute sit to stand test, which is the measure that we used as a remote outcome measure, the virtual patients, a higher percentage of those were achieved a significant improvement. And once we'd been able to resume face-to-face assessments, we started using the shuttle walk test again. And certainly the virtual patients again improved, made a more of a significant improvement. But compared to our face-to-face patients, it wasn't as much of an improvement. The chronic respiratory disease questionnaire results we have to interpret with a bit of caution, because the numbers of questionnaires that we actually received back from our remote patients was significantly smaller than face-to-face. But again, we saw that the handbook programme tended to be inferior. Yeah, we can move on. Thanks, Ellen. So just some benefits that we found from running the virtual programme. It's much more flexible for patients. So as we've said previously, those who work or perhaps there's travel limitations, patients who have other commitments, you know, they can do their twice weekly exercise programme as and when a time suits those. Definitely think it opens pulmonary rehab up to a group of patients that perhaps wouldn't have accessed it before. And in the current climate, those who don't feel confident to attend a group. Our normal face-to-face programme is quite gym-based, so we use a lot of gym equipment, whereas the home and online programme that was put together is very functional, which definitely benefited some people. In terms of the cons, as quite a few other people have said, accessibility and ability to use the online resources, we found a big issue, and it was actually quite time consuming on the team as well. We spent a lot of time talking through people accessing the website and accessing Microsoft Teams, and that took quite a lot of time. Lots of comments from patients about struggling to get motivated to exercise at home, and feedback from people that had done pulmonary rehab in the traditional way before, that they really missed the peer support. As has been commented previously, we felt that we couldn't be as accurate in terms of our exercise prescription. So we're used to prescribing a walking speed based on their shuttle walk test result, which we couldn't prescribe exercise in the same way. And then we found that there was a proportion of patients who we just didn't feel comfortable with setting them off with a programme at home, either because they didn't have suitable space or to exercise at home, or we had concerns about falls history, or they were on ambulatory oxygen and we just didn't feel that we'd got a grasp of what their sort of exercise requirements were. And also a sort of feeling amongst the team that those higher level patients, we couldn't exercise to the same intensity that we perhaps could have achieved in a gym. And at the same time, the lower intensity patients we felt didn't have the confidence to exercise at the intensity that we would have liked them to. So we have started face-to-face.
Sorry, Helen, we're just going to need to wrap it up in the next 30 seconds. Is that all right?
Yeah. Thank you. You click on to the next one, Ellen. So we have returned back to face-to-face, similar to Karen, with temperature checks, COVID screening checks, exercising people in bubbles, so using their own cardio equipment and then having their own set of weights, enhanced cleaning and recording of cleaning, but largely based on the BTS returning to face-to-face rehab document that was put out, really. We are still delivering the education remotely, so that's definitely food for thought for the future of the best way to achieve this, because we're currently doing a mix of handbook and online education. Need to look at that further. That's all, I think.
Fabulous. Thank you very much, Helen and Ellen. That's been really interesting to see how you've gone about changing your delivery and your service around the current challenges. There's lots and lots of questions coming in that I think relate to some of what you've been talking about and some of Karen's, and bigger issues as well. So I'll just pick up on something that I've just seen, is something about the exercise testing. So how did you find when you were doing your virtual rehab? How were you actually prescribing their exercise?
We did use remote monitoring. That was the thing that we forgot to say. We did deliver out sats and heart rate monitors to people, which again was an organisational bit of a nightmare. We used blood bike, men on motorbikes to deliver sats probe and things out to people. So we, our fitness instructors, the virtual programme that they put together had 3 levels, so level 1, 2 and 3. So level 1 was largely seated, and then it progressed through. So we got a kind of a rough feeling. So on the sort of 1 minute sit to stand score of roughly what level we would start people on. And then we used the Borg score. That was probably the main way that we prescribed the cardio component of exercise.
So how did you prescribe from the 1 minute sit to stand? I'm just interested to hear how you went about that.
It was a best of a kind of guess, largely, you know, what rough level ability we thought they were at, and then lots of education around the Borg score. And that's really why we moved back to face-to-face assessment as soon as we could, because we didn't feel it was an accurate way to prescribe exercise.
Yeah, absolutely. It's I think in terms of safety as well, isn't it? Yeah.
I think, you know, with the ones that we did do the 1 minute sit to stand on virtually, we did actually already have an assessment on them. So they had already been seen face-to-face pre-COVID. They got a walking test and things. So we had a vague idea of their level of sort of functional ability as well, prior to that separate sort of functional assessment with the 1 minute sit to stand.
Oh, thanks, Ellen. Has anybody else got any questions that you'd like to, you know, please just speak straight out. I don't know if you have, Lucy, either, about anything that we've just heard.
Whilst anyone gathers any questions, one of the themes that was coming up as I was reading through was around thoughts of whether or not there's a role for a kind of blended approach of both the face-to-face element, perhaps for the comprehensive assessment and exercise prescription side of things, and virtual. And I know from the survey we did as part of the ACPRC document that a lot of people were thinking that they were going to retain some elements of virtual or remote elements, such as a screening tool to start with, partial subjective. So I guess just thoughts from everyone on that really blended approach.
Please feel free to just turn your mics off and speak up.
Hi, it's Liz Hill here again. Thank you. This is really, I'm really loving this discussion. I'm really glad I've joined in. And I feel a little bit bad because I suppose we've really not allowed many of our patients really in Lincolnshire to access any face-to-face, just purely because our venues just weren't opening, and I wasn't fully probably aware of how the interpretation of the guidelines were. So that's been really useful for me. But in terms of the blended approach, we've been talking about it because we developed our own in-house virtual program using Microsoft Teams. We have been going out to patients' homes and visiting them and doing an assessment in the home, sit to stand tests, using and obviously doing Borg, heart rate, blood pressure, sats, etc. In the home. But we're thinking about that, and I'd like to try and investigate and look at a blended approach in the sense that when we are back to face-to-face, that could we potentially have a face-to-face class running at the same time as having a virtual group running. So you've got a group on a computer listening in at the same time. The only downside to that is connectivity. Obviously, you've got to be able to connect to these patients when you're running live programs virtually, and sometimes, certainly in Lincolnshire, that isn't always possible. Just wondered if anybody else had got any thoughts about that, anything they're looking at doing in the future, sort of blending those programs together.
I'll jump in briefly. We haven't tried it in pulmonary rehab, but our colleagues have in cardiac rehab. And they've said it does work quite well if you're doing sort of circuit style face-to-face, where everyone does a set interval of whatever's, and then they move on to the next one, and they move on to the next one, because then people can do that same sort of circuit at home with the intervals. But to try and blend face-to-face pulmonary rehab, where you might have people walking at completely different speeds and paces and other bits, with virtual is a lot more challenging. And so far there hasn't, I've kind of looked at how they're doing it, and I'm not sure it would work, although we're kind of exploring that a little bit.
No, thanks, Karen. That's really good to know. It's I think it's one of those things we've got to try some of these things, haven't we? To try and increase that accessibility for some of our patients, but also to be as cost effective and time effective as we can with our resources.
Brilliant. Has anyone else got, oh, go on, Teresa.
No, you carry on, Lucy.
I was just going to ask if anyone else had any other thoughts around or experience in terms of any blended approaches.
Sorry, Lucy, I was talking away with my mute on, usual.
Oh, were you?
My own little world. I mean, they've tried this in Canada, and this predates any pandemic because they're clearly challenged with geography. So they tried a blended approach where they offered the education combined, so people would be at home or in a different community centre where you wouldn't have the multidisciplinary team necessarily, with a site where they did have the multidisciplinary team, and the outcomes actually were no different at all. And interestingly, we've tried, because of, we all get challenged by having access to the multidisciplinary team on every site that we offer rehab, don't we? I think we all would be challenged with that. So we recorded videos of the talks, and actually the educational outcomes were no different, offering the education in that way. So I think that there are lots of things that we can do different potentially, but we mustn't throw the baby out with the bathwater. I think, I see so many people now saying, oh, well, we're just doing virtual and we're just going to do a 1 minute sit to stand. Well, that's not rehab. That might be supported self-management, but wouldn't fulfill the criteria for rehab. So I think it's really challenging. It's probably better than nothing, but I suspect it's not as good as rehab. So I think we still need to do lots of evaluation of these techniques that might work. And I think that if they do, that really opens up access to rehab and would be amazing. But we have to make sure that there's still high quality services.
Yes, absolutely. Just reflect, I read some studies recently about the use of satellites. I think again it was Canada and Australia where they're accessing rural areas, isn't it?
No, completely. And the telehealth studies are interesting from Australia because they have emerging evidence. At best, it's not that convincing really, but it's hugely time intense for the operator because you can only have a really small number on your screen at any one time. So, and the equipment that you require to do it is quite tricky sometimes. So, I suspect with all of these, Zoom equivalents now, it will become much easier, but I know that it's a challenge.
It is, isn't it? And I'm sure many people would be thinking about the kind of digital literacy side of things in terms of when you're offering the remote and thinking about your particular population.
It's interesting. I was talking to Anne Holland the other day and saying what was their experience, because their geography lends itself to being more remote anyway. And she said that patients and staff were just craving to go back to face again, which I thought was really interesting, because I said I couldn't really sense the mood music in the UK at the moment. I felt that some people were almost pushing to do everything remotely, which concerned me in terms of reaching the quality standards. But she reassured me that in Australia there's almost this pendulum back to please let me see somebody and do face-to-face rehab. So they didn't feel challenged by people not having a high quality intervention, which I thought was really interesting.
It is, isn't it? It's really interesting to compare how different countries have approached things, isn't it, and what learning has been taken. I'm conscious of time. We've only got 3 minutes left. I don't know where that went to. But Teresa, I didn't know, do you have any final questions you wanted to put to the group? Or...
there are a couple of things really that just from all of your comments today. So just to let you all know that the BTS, I think it's out now actually, isn't it? The reopening guidance from the BTS for pulmonary rehabilitation it should be available now. So that link, if you go onto the BTS website and look for that pulmonary rehabilitation reopening of services, there's some guidance that's been put in there and written by national experts. So please use that. That might be really informative in terms of some of the things that have come up today and some of the issues that have come up today. And the other thing is that, like I said at the beginning, we're hoping to do some of these webinars at one every month. And the next one, which leads on really nicely from thinking about quality standards that Sally was just talking about, is the next one's going to be on accreditation. And that's going to be on the 19th of May. Yeah, just to let you know that we're hoping to put more of these on. But what we would like from you over the next couple of minutes is just to write down any ideas in the chat bar about things that you'd really like to do with other webinars that we could do. You know, things that you really want to hear about and that are important for you out there delivering pulmonary rehabilitation to try and, you know, get back to pulmonary rehabilitation as we know it, thinking innovatively, but I think as Sally said, we have to make sure that what we're doing is at a quality standard and is from recommendations to give that best quality care really. So please, any ideas for anything else you'd like to discuss, please put in the chat bar. I don't know if there's anything else, Lucy. I would like to say a massive thank you to Sally, to Karen, to Ellen and to Helen. All of you, thank you so much for your time tonight. It's been really interesting. It's got us all talking about really important and passionate things. And thanks, Lucy, for co-chairing, and the ACPRC for hosting this as well. So thank you so much. I don't know, Lucy, I'll hand over to yourself for anything else.
Yeah, no, I was just going to reiterate as well, just for people to put in their diaries, 19th of May, 8 o'clock. More information will be in the ACPRC newsletter and we will be advertising very soon. So just keep that time saved. And yeah, just again, another big thank you to everyone, and thank you very much everyone for joining and all of your questions and comments. We could go on and on, and I'm sure we will in the series of webinars. But yeah, enjoy the rest of your evenings. I think we'll sign off there.
Fantastic. Thank you, everybody.
Take care.
Bye.
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 Bye.